Today we will learn for ST segment elevation assessment and key to identifying ST elevation MI or acute MI is new ST elevation at J point and two contiguous leads with cut points more than or equal to 0.1 millivolt above the beginning of QRS complex. Use PR as baseline. If PR is depressed, use TP segment. Lead V2 to V3 ST elevation more than or equal to 0.2 in men above 40, 0.25 in men below 40, or 0.15 millivolt in women. J point is the juncture of QRS and ST segment as shown here. You can see different ST elevations including the tombstone ST elevation. Convex elevation is classic tombstone, usually localized regional rather than widespread. Serial ECG analysis in same place and correlate with clinical picture for correct diagnosis. Other kinds of ST elevations include acute pericarditis, clinical diagnosis with ECG findings with widespread ST elevation with PR depression seen. Benign early polarization is prominent J point elevation more than or equal to 1 mm in more than or equal to two contiguous inferior or lateral leads. J point notching or elevation and upward concavity in leads other than V1 to V3. Clinical cues are historic ECGs with same patterns, no reciprocal depression, more common in young healthy males, uncommon above 50-year-old. Fishhook pattern, concave elevation in BER. ST depression. ECG ST depression criteria of acute MI is new horizontal or downsloping ST depression more than or equal to 0.05 millivolts in two contiguous leads. Clinical cues: if ST depression is present in anterior leads, posterior leads should be recorded to investigate possible posterior MI. If STEMI or SCS, arrange stat care. Important T wave changes. ECG T wave changes for acute MI. T inversion more than or equal to 0.1 millivolt in two contiguous leads. T inversion more than or equal to 0.1 millivolt with prominent R wave or R to S ratio more than 1. Potassium abnormalities. ECG is not the diagnostic test of choice for electrolyte abnormalities, but below morphologies are noted in potassium abnormality. Hypokalemia with flattened T wave, hyperkalemia with peak T wave, and sine wave in severe hyperkalemia above 9 millimole per liter. Use guide at right for precordial lead placement. In case of diagnosing the MI, you will put leads in this sequence. Leads V1 to V2 often misplaced in second intercostal space versus fourth intercostal space. Clues to limb lead inversions. P wave is negative in lead 2, global negativity in lead 1, QRS complex upright in AVR. So when the limb lead reversal or inversion occur, these changes will be seen. Stay tuned for more on ECG.